Well, good morning. Thank you for the opportunity to present again. And Dr. Uday Devaskar gave me the challenge to speak to you about advancements in GI drugs. And the title of my presentations is Myths versus Reality. I'll speak to you briefly about GI medication use in the NICU. And then specifically, we'll talk about pharmacotherapy aimed at treating gastroesophageal reflux or gastroesophageal reflux disease, feed intolerance, and cholestasis. And yesterday we spoke about contemporary multidisciplinary approaches to intestinal failure, specifically alterations in dose of intravenous lipids and composition. And I won't touch on fish oil such as Omegaven or SMOF today, but I'd be happy to answer questions after this presentation. So I'd like to begin first with just a question for the audience. Does your NICU prescribe anti-reflux medications for preterm babies? A, never, B, sometimes, C, often, and D, all the time. Approximately 65% sometimes. So let's talk about medication use in the NICU, and most of this data is from the United States, and there's certainly some European databases that support the American data. And the question is are neonatologists polypharmacists? So this is a retrospective study using an electronic medical record from Pediatrics, which is a group in the United States that serves over 200 NICUs in the states and the surrounding territories, and are known for their excellent EMR. And what they tried to do in a retrospective fashion was to figure out the frequency of anti-gastroesophageal reflux medication use. So not surprisingly, as we discussed yesterday in our journal club, the top two medications prescribed in the NICU are ampicillin and gentamicin. But not far behind at number 10 is metoclopramide or Reglan, a pro-motility drug, and at number 15 is ridantidine or Zantac. So they're often prescribed in our NICUs. And this also they published was the use of cisapride, which declined at approximately 1999 and 2000, and that's when the FDA issued an alert with regards to this drug and its association with arrhythmias. But what we see here, as the use of cisapride decreased, we see an increase in the use of Reglan and ridantidine. And also, if you extended this graph to 2013, I'd bet that we'd see an increase in the use of proton pump inhibitors. And this was a study that was performed by the NICHD NRN, which we spoke about earlier, the Neonatal Research Network in the United States. And this was a retrospective study to determine risk factors for the use of anti-reflux medications, which was a proxy for the clinical diagnosis of gastroesophageal reflux disease in ELBLs, so babies less than 1 kilo. And the data was collected over 2 years, 2002 to 2003, and they followed these babies to 18 to 22 months post-menstrual age. And they were also interested in looking at an association of the clinical diagnosis of reflux and its effect on growth and neurodevelopment. And what you see here at baseline is that approximately 25% of ELBLs are discharged home with anti-reflux medications. And then if you look at postmenstrual age, you'll notice that this incidence actually increases the longer the baby is hospitalized in the NICU. So for babies who are greater than 42 weeks postmenstrual age, as represented here by the black bar, you see that they're more than 2 times likely to be prescribed these medications. And they were specifically looking at H2 blockers, PPIs, and pro-motility agents such as Reglan. And not surprising, medication use varies by center, regardless of the postmenstrual age of the neonates. And then they also did a regression analysis looking at specific variables that were associated with this outcome, which was anti-reflux medications at discharge. And what we see here again is center is an important variable, but in addition, gestational age and race. So the more premature the neonate, the more likely they're to be prescribed an anti-reflux medication. And interestingly, in the United States, race was also a statistically significant variable, with Black neonates and Latino neonates being more likely to be prescribed these medications. And when they broke this analysis up by postmenstrual age, those discharged at greater than 42 weeks, these variables no longer were significant. And so the second part of their study was to answer whether or not gastroesophageal reflux predicts poor growth or neurodevelopment. And as all of us are aware, many people believe that gastroesophageal reflux causes apneas, bradycardias, and desaturations, which then may cause poor growth and poor neurodevelopment, or that feeding intolerance is secondary to gastroesophageal reflux, leading to these outcomes. But what they saw was that those who were prescribed medications, their growth and their neurodevelopmental scores were no different than those who were not prescribed anti-reflux medications, thus dispelling this myth. So what is gastroesophageal reflux? And is this really a problem in our NICU? Well, simply put, it's defined as retrograde movement of stomach contents into the esophagus. It can result in gastroesophageal reflux disease, which is considered pathological and not physiological, which then can result in poor growth, respiratory issues, and esophagitis. And this is well established in pediatric and adult literature. And the idea behind pharmacotherapy is to interfere with this process and thus reduce the negative sequelae associated with the disease. So why are neonates, specifically preterm babies, at increased risk for gastroesophageal reflux? Well, there's 3 reasons. One is they're often in the supine position, they have a large fluid intake, and transient lower esophageal sphincter relaxation. In other words, their LES is weak, and this is the main problem or the main cause of gastroesophageal reflux in our population. So with regards to gastroesophageal reflux, like I mentioned, this is probably most likely a physiological process and not necessarily a pathological process. It occurs at least with 1 feed daily among 50% of infants younger than 3 months, and this is term babies. And 2/3 of 4-month-old babies regurgitate daily, meaning that this is a common quote-unquote problem. And in preterm babies, the quote-unquote incidence, depending upon the paper you read, is anywhere from 40 to 85%. And it's certainly increased in the neurologically impaired and possibly those with cyanotic heart lesions. And as we all know, this quote-unquote disease or process improves with time. So how can we diagnose gastroesophageal reflux? And are we able to truly diagnose this quote-unquote disease? Well, first is radioimaging. And we often use upper GIs, but these are not sensitive and specific. And really, these studies should be used to define anatomic risks. So for example, a baby who's being taken for a G-tube, you want to make sure there's not a malrotation. You can also perform these studies simultaneously with a gastric emptying study to look at motility. But the point here is that an upper GI cannot diagnose gastroesophageal reflux. pH monitoring, now certainly that's the gold standard in pediatrics and adult literature, but it's certainly not the gold standard in our population. And the reason being, and I'll show you on a slide coming up, is that neonates mainly have non-acid reflux, making pH monitoring obsolete and not a sensitive or specific test. So neonates' pH is usually greater than 4 for an extended period of time, and that's for a multitude of reasons. They're often on continuous or frequent feeds that neutralize the pH, again, making pH monitoring not a good test to diagnose gastroesophageal reflux. And next is impedance monitoring, which we'll talk about. So impedance monitoring is often employed in research studies, and it can be used simultaneously with a pH probe. And so what you see here is you see a pH probe, and at 2 places you can detect changes in pH, one in the stomach and the second above the LES. And next to that is the impedance monitor, which can detect changes in impedance at various time points. And if you have a refluxate or a retrograde bolus that moves up into the esophagus, there'll be a change in impedance or a drop in impedance, which will then signify that there's a reflux episode. And here's a tracing of an impedance monitor. So what you see here is that the impedance drops, indicating that the child or the baby is experiencing reflux, and simultaneously you can monitor vital signs to see if this reflux episode is truly associated with apneas, bradycardias, desaturations, and again, you can also look at changes in pH above the LES. So as I mentioned, neonates do not have acidic reflux, and this was a nice study done in 2006, and when you see here is that only 25% of the time do preterm babies have acidic reflux, and in fact, 3/4 of the time, about 75%, their reflux is weakly acidic. And their total acidic reflux exposure to the esophagus is less than 2%. Again, making pH monitoring not a good test in our population. So with regards to diagnosis of gastroesophageal reflux, we really don't have good studies, and many of us rely upon our clinical intuition. And there's no, as I mentioned, there's no standards. And in fact, the North American Society of Pediatric Gastroenterology and Nutrition states that guidelines for the diagnosis of this disease, or quote-unquote disease, is not intended for babies less than 72 hours, for premature babies or neonates with neurological impairments. And the American Academy of Pediatrics, the AAP, also supports this statement. However, as I mentioned to you earlier, anti-reflux medication use is extremely common in NICUs throughout Europe and America. And in fact, some studies report an incidence of over 85% of babies receiving these medications. So what medications do they use? They're often prescribed gastric acid reducers and promotility agents. So with regards to acid reducers, we have H2 blockers or histamine 2 blockers. And these medications block the histamine 2 receptor in the gastric parietal cell, thereby decreasing acid in the stomach. There's also PPIs, or proton pump inhibitors, and these medications inactivate the proton potassium ATPase pump that's responsible for secreting hydrogen ions from the parietal cell into the stomach. And here's a quick schematic that sort of depicts how these medications work. Basically, you have a baby who's been fed, and that leads to stomach distension and an increase in acetylcholine. Acetylcholine stimulates the parietal cell. In addition, your food is broken down into peptides or amino acids that stimulates the G cell and releases gastrin, which then stimulates ECL, which releases histamine, which then binds to the H2 receptor, stimulating the parietal cell to secrete HCl via this ATPase. And as you can see here, H2 blockers block the H2 receptor, and PPIs block this ATPase. So what about promotility agents? How do these medications work? Well, cisapride, which I mentioned to you, was withdrawn from the market in 1999-2000 for its association with arrhythmias. And it's a serotonin, specifically a 5-HT4 agonist. And the reason why it was associated with arrhythmias is that it had a non-specific affinity for serotonin receptors. In addition, it interferes with the P450 system, specifically CYP3A, and when it's used simultaneously with erythromycin, you can have an increased risk for arrhythmias. So what about Reglan or metoclopramide? Well, it acts in various places. It acts in the CNS and the small bowel and systemically. In the brain, it's an antagonist of the serotonin receptor, specifically 5-HT3, and the dopamine receptor, D2, producing an antiemetic effect. It also increases acetylcholine, and this is its main mechanism, which thereby increases LES and gastric tone, also improves gastric emptying, and improves anteroduodenal coordination. Simultaneously, it acts in the small bowel, and it's a stimulant of the 5-HT4 receptor in the proximal small bowel, and then it inhibits the D2 receptor. And this also increases LES and gastric tone and improves coordination. And again, it's important to remember that Reglan works in the proximal small bowel, not in the distal small bowel. With regards to dosing of Reglan, data suggests there's a developmental dependency. And this is exactly why when we prescribe Reglan to preterm babies, the dose is increased from 0.1 to 0.15 mg per kg every 6 hours. And that's because in preterm babies, it's extensively metabolized by the liver. So the next question I have is, are apneas and bradycardias just temporally associated with reflux? So in other words, does reflux cause apneas, bradycardias, or desaturations? Well, in the 1980s and early 1990s, there was the idea that this association truly existed. And what many people thought was that gastroesophageal reflux could induce apnea via activation of the laryngeal chemoreflex, causing a respiratory pause after regurgitation into the airway, and that a reflux episode traveling up into the esophagus could also lead to obstruction. But it's important to remember the mechanism behind these two processes. As we talked about earlier, gastroesophageal reflux, the risk factors include a supine position, liquid feeds, and large volumes of feeds compared to an adult, and lastly, and the most importantly, a weak or relaxation of the LES. Apnea, on the other hand, is caused by 3 mechanisms: increase in inhibitory reflexes, a decrease in the hypercapnic response, and hypoxic depression. And so the question is, are these truly related? Does one cause the other, or is it just truly a temporal association? So here are some studies from the early 2000s, and these studies have been replicated over and over again, sort of dispelling this myth. And this is a small study of 19 neonates with apnea prematurity who underwent 26-hour recordings with impedance monitoring. So impedance monitoring was also performed simultaneously with pH monitoring in the study. The median gestational age was 30 weeks, so these are preterm babies, and the age of the study was approximately 1 month. Median apneas was approximately 67, median reflux episodes was 25, and the frequency of apnea occurring within 20 seconds of a reflux episode was not significant when compared to reflux-free episodes, meaning that there's no association. And these studies have been replicated with regards to desaturations and bradycardias. And here's another study that was published by Kathleen Kennedy at the University of Texas and published in 2009. And it's a small study, but the results are quite intriguing. So they enrolled a total of 18 neonates, and only 17 completed the study. And the goal of this study was to determine if anti-reflux medications reduced bradycardic episodes attributed to gastroesophageal reflux. And their inclusion criteria was preterm babies, those less than 37 weeks, and less than 44 weeks post-menstrual age, a clinical diagnosis of gastroesophageal reflux by the medical team, and a physician who was planning to start anti-reflux medications because of bradycardias that they attributed to gastroesophageal reflux. And this was a masked crossover trial comparing metoclopramide and rodantidine with placebo. And it was an N of 1 design, which is actually quite clever and a very efficient study design. And they had two groups. One was drug first, and the second was placebo first. And in the drug first, for the first 3 days of the study, the neonates or the subjects received the combination therapy. For the next week, they received placebo, and then that was followed by another 3 days of intervention. Where in placebo first, it was reversed. The first 3 days were placebo, the next 7 days or week were with intervention with Reglan and rodantidine, and the next 3 days were with placebo. So this allowed for a washout. And the primary outcome was number of bradycardias. And what you see here is that bradycardias were decreased with placebo, not with the intervention. So you can see here, this dark bar represents drug periods in both groups, while the white bar represents placebo periods in both groups, and you see a difference. Moreover, which is not surprising, bradycardias improve with time, and you can see time period 1, 2, and 3. And what they concluded is that in the adult population, rodantidine in adults is actually associated with tachycardia, bradycardia, and premature ventricular beats. So what about pro-motility agents, specifically metoclopramide? Well, a Cochrane meta-analysis demonstrated a reduction in gastroesophageal reflux symptoms, and in fact, the treatment effect was minus 0.43 with a significant p-value. However, in all of this meta-analysis, there was an increase in side effects. And in fact, there's a long list of side effects which include irritability, dystonic reactions, drowsiness, ocular issues, emesis and apnea, which is exactly what we're trying to prevent, and also galactorrhea and gynecomastia. But metoclopramide certainly is effective, and as I mentioned, there's various ways that this drug works. It attacks the CNS system, it increases acetylcholine, and also attacks the small bowel. And this leads to a decrease in gastric aspirate, improved transient time, decreased regurgitation, and time below a pH of 4. What about other side effects with these medications? Could we be harming our babies? And I think there's good evidence now that's been published in the past couple of years suggesting that H2 blockers are associated with an increased morbidity and mortality in our preterm baby, and specifically with regards to infections and necrotizing enterocolitis. So this was a multi-center prospective observational trial of babies less than 1.5 kilos. And what they did is they looked at those who were exposed to rodantidine and compared those to those who were not exposed to the drug. And basically what they saw that there was an increase in overall infections, specifically sepsis, pneumonia, and UTIs, all of which were statistically significant. So with regards to infections, those exposed, the percentage was approximately 38%, compared to those not exposed was approximately 10%. And this is another study that supports this study that was performed in the Neonatal Research Network. And they looked at necrotizing enterocolitis. And they matched their cases, or babies who had or who were diagnosed with necrotizing enterocolitis, 3 to 1. In other words, for each case, there was 3 controls. And what they saw here was that H2 blockers, whether it was truncated according to gestational age or chronological age, was absolutely associated with an increased risk of NEC. and in fact, the odds ratio is 1.7 and 1.5. So why this association? Well, it's certainly not surprising. Basically, when you change the pH, you're changing the microbiome. A normal pH for a preterm baby is approximately 3 to 4, specifically for ELBLs in the first 3 days of life, and then it declines even further by day of life 16. And this low acidic environment is protective for numerous reasons. And as I mentioned, changing the pH probably changes the colonization of the GI tract. And this is certainly consistent with adult and pediatric literature that's also published an increased risk of infections with these drugs. What about other concerns with these drugs? Well, gastric acid is required for pepsin activation, which metabolizes protein. And our babies are at increased risk for feeding intolerance. So by changing the pH, they're going to be less likely to metabolize their protein. Gastric acid is also important for vitamin B12 and calcium absorption. And in fact, adult studies have linked gastric acid suppressors with poor bone density. And our VLBLs are certainly at high risk for osteopenia and fractures. Altering the stomach's acidity may decrease the bioavailability of other drugs. And ranitidine is associated with reversible bone marrow suppression and CNS side effects. So these are true concerns with the use of this drug. What about PPIs? As I mentioned, there's a rise in the use of PPIs. And while 2 randomized controlled trials in preterm and term babies showed no improvement in gastroesophageal reflux, despite decreased esophageal acidity, these drugs are still being used. And again, while it's not extensively studied, we would assume, just like an H2 blocker, a PPI would be associated with an increased risk of infection and necrotizing enterocolitis. And in fact, the FDA issued a safety alert and class labeling change for PPIs, citing evidence that in adults, you're increasing their fracture risk. And again, our VLBLs are certainly at high risk for osteopenia and fractures, and thus these drugs could be exacerbating this problem. What about other concerns of metoclopramide? As I mentioned, there's an array of side effects, and as a result, there's an FDA black box warning. And as a result, if we do use these drugs, the AAP suggests they should be used for a limited time period, approximately 7 days. And if we don't see improvement of symptoms, we should withdraw the drugs. And we probably should be counseling parents about the use of these drugs and the side effects. So as I mentioned, the AAP has a staunch stance about these drugs, and it also states that off-label use of drugs should be based on sound scientific evidence, expert medical judgment, and published literature. So really the question is do we just need to be patient with our preterm babies? But what about other populations, specifically those who are neurologically impaired and those with cyanotic heart lesions? And this is something I don't have time to discuss, but there's certainly a lack of research and data about how to treat quote-unquote reflux in this population and sequelae from using these medications in these populations. So next, I'd like to turn your attention to medications to reduce cholestasis, and then lastly, feeding intolerance. So feeding intolerance in the preterm neonate. Well, it's probably due to a multitude of issues, but many people have attributed it to a lack of the propagation of phase 3 migrating motor complexes, or MMC. And MMC, as you may be aware, is under the control of a hormone called motilin. However, it's unclear if these receptors are actually present in babies less than 32 weeks. In addition, feeding intolerance is secondary to a lack of lipase and bile acids. And in fact, the fat content of the small intestine, specifically the duodenum, is the major determinant in gastric emptying. So what about the incidence of cholestasis in preterm babies? Well, there's certainly numerous risk factors. There's an increased risk in the IUGR SGA population. Sepsis and NAC aggravates the situation. And lastly, feeding intolerance and long parental nutrition courses increase the risk of this disease. And approximately over 12,000 babies will develop some form of liver dysfunction each year in the United States, secondary to parental nutrition. And 90% of premature babies who receive IV nutrition for greater than 3 months will develop parental nutrition-associated liver disease, or IFALD. So the idea behind pharmacotherapy is that if we improve feeding intolerance, we'll shorten the duration of IV nutrition and thereby decrease cholestasis. And the pharmacotherapy available to us is uricadiol or Actigol. And then also there's published literature regarding erythromycin. And another question many people have have is, can uricidil actually improve or directly improve feeding intolerance by specific mechanisms? So again, the medications to treat cholestasis are motility agents such as erythromycin and then Actigol, which is a synthetic bile acid. So what medications do you use in your NICU to improve feeding intolerance? Do you use acid reducers, promotility agents, a low or a high dose erythromycin, or Actigol? So it looks like the vast majority of people use promotility agents, which I assume would be a medication like metoclopramide. So again, medications for feeding intolerance and cholestasis. So erythromycin, which has been studied in several randomized controlled trials, inhibits the motilin receptor, thereby improving the propagation of these migrating motor complexes. However, it should be noted that it's unclear in the ELBL population if this receptor is even present. It's associated with the use of pyloric stenosis, and that's been well established outside of RCTs in both the high and the low dose. However, in RCTs, we haven't seen an increased risk in pyloric stenosis, but outside of RCTs, this adverse side effect has been reported. Erythromycin also inhibits CYP3A, thereby increasing the risk of arrhythmias when used with other CYP3A inhibitors, which is important to remember when you use this drug. And then with regards to uricidil or Actigol, it's basically a natural bile acid. It decreases hepatic secretion and intestinal absorption of cholesterol, and it also exchanges hydrophobic for hydrophilic bile acids, thereby making and decreasing the risk for feeding intolerance. So can erythromycin improve feeding tolerance? Well, there was an RCT of 182 neonates randomized to receive either drug versus placebo, and the dose of the drug was a high dose erythromycin dosed at 12.5 mg per kg every 6 hours, so that's equivalent to the antibiotic dose. After 14 days of life, if the neonate was receiving less than 75 cc's per kilo per day of enteral nutrition. And their primary endpoint was 50% reduction in the incidence of cholestasis. So they were aiming to reduce cholestasis from 40% to 20%. And that's a huge jump if you can achieve that in a clinical trial. And they used high-dose oral erythromycin after 14 days of life for a couple of reasons. First, it's been noted that the risk for pyloric stenosis is increased prior to 2 weeks of life, and that increase disappears after 2 weeks of life. And it's the IV formulation that's associated with arrhythmias and not the PO formulation. And so what were their results? Well, there was a decrease in parental nutrition-associated cholestasis. They were able to drop their incidence from 40 to 20%, and so their p-value was 0.003. There was a decrease in the duration of parental nutrition and interlipids, and an increased time to full enteral feeds. There was no change in bilirubins, but a decrease in the maximum ALT, a decrease in sepsis, which is surprising, and also they looked at resistant organisms in the bowel flora, and there was no change. And there was no adverse events, specifically necrotizing enterocolitis, cardiac arrhythmias, and pyloric stenosis. So can Actigol prevent, not treat, but prevent cholestasis and improve feeding intolerance? So here's another RCT of 15 preterm babies who were randomized to receive either Actigol or placebo. And they dosed the Actigol at 5 mg per kg per day on day of life 3. So these are babies who are not necessarily receiving enteral feeds. And then it was doubled at full enteral feeds. And then once the patient established full enteral feeds, it was increased to 20 milligrams per kilo per day. And their primary endpoint was looking at fecal fat and time to full feeds. And they were hoping to reduce these two primary endpoints by approximately 20%. So what did they see? Well, fat excretion or fecal fat excretion did not change at all. And while the Actigol group reached full feeds 2 days earlier, there was no statistical significance. And why is that? Well, because preterm infants rely heavily upon gastric lipolysis, accounting for about 25% to 60% of lipid digestion. In other words, increasing the bile acid pool is not going to be enough. But what they saw, which was not surprising, and this was again a preventative trial, is that GGT serum concentrations were decreased in the group that received Actigol, thereby presuming that there's a decrease in parental nutrition-associated cholestasis. And it's been well established in the pediatric population, even the preterm population, that Actigol is efficacious and safe for the treatment of cholestasis secondary to parental nutrition. Here's another trial comparing erythromycin versus Actigol versus placebo. And again, this was an RCT, a randomized controlled trial. And babies were randomized either to Actigol at 20 mg per kilo, so the standard dose, versus erythromycin, again a high dose, versus placebo if they weren't receiving full enteral feeds by day of life 14. And what they saw was a decreased time on parental nutrition with erythromycin, and Actigol was associated with a decrease in serum GGT. And there was no adverse events, specifically arrhythmias, necrotizing enterocolitis, or pyloric stenosis. So I'd like to conclude with regards to gastroesophageal reflux. There are no standards or diagnostic tools for gastroesophageal reflux disease in the preterm population. Data is certainly lacking to support the efficacy and safety of H2 blockers and PPIs despite its wide use in our NICUs. H2 blockers increase the risk of infections and necrotizing enterocolitis. And while Reglan may improve gastric emptying, it certainly is associated with an increase in side effects. With regards to feeding intolerance and cholestasis, Actigol treats and possibly can prevent cholestasis, but it does not improve feeding intolerance. And erythromycin may improve feeding tolerance and decrease cholestasis, but is associated with the possible side effects that have not been seen in the small RCTs that have been published to date. Thank you.